My name is Lynn Carver. I'm the Director of Clinical Services at Willow Springs Center. We're a residential treatment facility for children ages 5 up till the age of 18. We serve every major Axis 1 diagnosis in our pediatric, and also we have a journey program for teens that's girls and boys. And then we have a specialty program at our hospital for dialectical behavior therapy. And it was primarily developed for people who have borderline personality disorder. And so we're going to kind of talk about that a little bit today. Our DBT unit was started about 6 years ago with the assistance of Dr. Alan Frizzetti. And Dr. Frizzetti is one of the cohorts for Marsha Linehan, who actually developed the DBT, or dialectical behavior therapy, over 30 years ago. And what she found over 30 years ago is that she was working with the hardest patients, patients that other people wouldn't take, with high levels of suicidality, high levels of self-harm. And she had some people who spoke into her life and said, hey, you need to write down what you're doing and how you're doing it, because this is really working. Who in here has had exposure to or any learning experiences around borderline personality disorder? Okay, what about dialectical behavior therapy? Okay. Is anybody in the room intensively trained in dialectical behavior therapy? Okay. Well, this is not an intensive training for sure. This is 2 hours. Intensive training is 80 hours of training by some cohort of Marsha Linehan, which Dr. Frizzetti is. And so what we're going to do today is learn enough about DBT so that you can incorporate it into the other treatment modalities that you're using in your practice. This training is something that you can take and refer to, and to be able to integrate with your other types of therapy that you're doing with patients in your offices. So DBT, as I said, was developed by Marsha Linehan about 30 years ago, or over 30 years ago. And she mostly treated women with borderline personality disorder. And as I said, she was encouraged to systematize what she was doing because her colleagues found that what she was doing was helpful and worked with the hardest of hard clients. So what we know is people who meet criteria for borderline personality disorder, or even close to borderline personality disorder, represent about 1 to 3% of the population. And that's pretty small, but they make up a very high percentage of people who seek our services. And so I think it's really important to know how to effectively be able to work with these clients in whatever types of setting that you're in. My experience, I have a lot of experience working both with adults and children, but for DBT, my experience has mostly been with children. So a lot of my examples are going to be case examples of adolescents. It doesn't mean that they're not, I think it will still be directly relatable to those of you who work with adults, or mostly adults. So DBT was developed to treat severe and chronic problems, right, associated with Axis 2 behaviors. The focus is on the role of emotion dysregulation in these problems. And what that means is, there's however many criteria that you need. I think it's 7 of 9 or 6 of 9 or something like that to have the diagnosis of borderline personality disorder. And so there's over 200 combinations of different presentations a patient could have and still meet criteria for that diagnosis. And then there's even more people who might have 5 of 9 or 6 of 9 or 3 of 9. And what we're going to talk about today, can still be effective with those patients as well, because the main component that we have found is that it's an emotion dysregulation problem that we're dealing with. And so all of these strategies and all of these things we're going to talk about are to help people who have emotion regulation problems. The overarching goal of DBT is to help patients create a life worth living. So we know that the lives of suicidal borderline patients are miserable. We know that they live in misery. They have a lot of misery. We know their relationships are a mess. They polarize all the time. And so we really want to help them learn skills so that they can create for themselves whatever a life worth living for them means. And and I love that. I love that goal, that's our goal for them. So when people come and show up with these Axis 2 types of qualities or behaviors or symptoms, we refer to them as having skill deficits rather than character deficits. And we're going to really talk a lot about, even though it's a personality disorder, right? So we're really going to talk a lot about what is the makeup of someone, both biologically and then from a nurture standpoint, environmentally, how these people develop and get more and more emotionally dysregulated over time in their lives. So you guys will go away with a good understanding of that as well. So one of the things that sets DBT apart from other therapy modalities is the use of mindfulness. And what Marcia did is she took Buddhist mindfulness, the practice of Buddhist mindfulness, and incorporated it into as one of the 5 components of DBT. And it's a very important component because it's all about attention, okay? So what mindfulness means in the context of DBT is paying attention on purpose. So if an elephant were to run through this room right now, we would all be paying attention to that because it's a big stimulus, right? And some of us may have an experience of that being I would probably be scared, a scary experience. Some of us might love elephants and think it's super cool and be very excited, right? But we would all be paying attention to it because it's going to grab our attention. It's that big of a stimulus, right? Versus paying attention to something on purpose, which involves things like deep breathing, eating mindfully, showering mindfully. It's exactly doing one thing at a time, one mindfully, okay? And so when we talk about mindfulness, we talk about 3 different mind states. We talk about having a reasonable mind, which concerns itself with facts and things that are observable. They can be manipulated with our 5 senses. You know, we can really see and feel and touch and taste and hear those types of things. And then our emotion mind, which is more of the subjective part of ourselves. It's about what we like. It's about our feelings. It's about opinions. It's about our desires, okay? And so then we have wise mind, which is the culmination of those other 2 mind states, all right? Wise mind culminates both emotion mind and reasonable mind, okay? So, and the reason this is important is for decision making. So if I want to go buy a car, let's say, and I only buy a car with reasonable mind, I'm probably going to get a pretty good car, right? I'll probably pay attention to gas mileage, cost, can I afford to insure it? What does the Blue Book say? What does this Consumer Report say? That kind of thing. But unless I bring in my emotion mind, I might not be that happy with it, right? So if all I do is buy a car that cuts, takes into account the facts of the car and how well it runs and those kinds of things, I still might not like it very much. So I'm going to be much more happy with my purchase, right? If I take it both into consideration, not just one or the other. So if I like the color, right? If it goes 0 to 60 in however many, minutes or whatever. If it is a body style that I really like, right? If it can lug camping gear, if that's what I'm into, right? I'm going to be much more happy with that decision. So what we really talk to our patients about, our kids about, and parents about is how do we get to wise mind and how do we stay in wise mind more often? Because we make much better decisions and we are able to build a life worth living the more time we're able to spend in wise mind. So what we know about our patients who have emotion dysregulation is they have, if we were to line everybody up in a continuum from the most emotional person to the most non-emotional, or perhaps the most intellectual person, right? Our patients are down here on this end of the continuum, right? They spend a lot of time in feelings, and they experience their feelings very, very intensely. And so it's teaching them how to notice, because their reasonable mind is there. They're able to notice these things. They don't have a lot of practice or experience doing that. So we introduce them to that side of their brain or that side of their mind, and we help them notice it so that they can make better decisions as they move through life. to be mindful, we have how skills and what skills. And the how skills of mindfulness are observe, describe, participate, or POD, as our kids like to turn even the things that we don't have as an acronym into an acronym. So participate just means making that decision. I'm going to do this task right now, okay? And in order to be mindful, if I'm not observing and describing, that is not the definition of mindfulness. So how to be is observe, describing, and participate. I think I have that backwards, actually. The what skills are observe, describe, and participate, and then the how skills, I'm sorry, I made that mistake. The how skills are actually one, mindfully, non-judgmentally, and effectively. Okay, so it's pod 1 if you're a fan of acronyms. So in order to be mindful, not only do we have to observe and describe and participate in whatever it is that we want to be mindful about, but we have to do it one mindfully. That one thing is what we're going to pay attention to. And I don't know how many of you in here have already noticed your mind wandering from what I'm talking about, but I'm going to guess it's a lot of us because that's what our mind does. Our mind does wander. So what we just want to be able to do is notice that our mind has wandered and bring it back. Okay, and then that's one mindfully. It's just being aware of where is my brain right now. And that's what we'll say to our patients a lot is they'll say, I tried this skill and it didn't work. And one of my first questions is, did you take your mind with you? Because if I do a skill and all I'm thinking about is how much I hate that other kid across the cafeteria, that skill's not going to be very helpful to me. But if I do that skill and I do it mindfully, right, I'm going to get a lot more relief from it. And so non-judgmentally is what we call NJS, which is non-judgmental stance. And so that goes back to the wise mind, reasonable mind, and emotion mind, reasonable mind, and wise mind. When I'm non-judgmental, I'm just describing the facts, right? What anybody could see and describe about that situation. I'm not putting value judgments on it. I'm not saying something is good. I'm not saying it's horrible. I'm not saying it's terrible. I'm being very non-judgmental, right? So that would be saying that there was a lady in the front who was wearing a flowered dress, and if I then said, and I really liked the dress, or I really hated the dress, that's when the judgment comes in, okay? So we're not practicing mindfulness when we're allowing our judgments to come through. And then we want to do it effectively. And then that just comes back down to being aware of where our mind is, bringing it back once it's wandered, because that's what our minds do. And remembering that I'm just going to focus on this one thing, okay? And we're going to go through some examples of mindfulness activities and how you can use them and work with your patients or clients. So in order to have, at Willow, what we're working on is having a fully adherent DBT program. And Marcia Linehan's corporation called Behavioral Tech is working on certification process for both clinicians. So clinicians can now become not only intensively trained, but they can become certified DBT therapists. And then the next step that they're going to be doing is certifying programs as being DBT adherent. That criteria, well, the criteria is there, but the way they're going to do that certification hasn't been finalized yet. So when I say we're working on an adherent program at Willow Springs, that means two things. They don't have the criteria completely set and how they're going to measure it, and adherency is always the target that's just a step away from you, right? Left unto itself, any program is going to become non-adherent. We have to be very mindful and purposeful in order to maintain and have an adherent program. So we have all the components to have an adherent program at Willow Springs Center, and we continually try to strive to make sure that in practice we're also adherent. So the 5 modes of therapy within DBT are to enhance people's capabilities, and that means skill acquisition and practice, right? So we need to teach people skills so that they understand them, and then we have to get them to use those skills in the midst of distress and outside of feeling distress, just so that they get a sense for what it feels like to do a particular skill. We need to improve motivation in our patients, and so that what targeting means is that we have targets for their behavior, and there's a hierarchy we'll talk about in a few minutes, but we're going to target perhaps self-harm, right? That might be what we're improving motivation on, is the patient to become willing to and interested in managing their emotions or getting relief from their emotions in a more effective way. And so that's usually done in individual therapy, and it does use behavior change, which is a huge part of my presentation today. We also want to be able to generalize skills to the environment, right? Often the first time a person uses a skill or avoids their target behavior, right? Let's say I'm targeting self-harm with a patient. The first time they get through a really difficult situation without going home and cutting afterwards, they've probably white-knuckled it through somehow, right? So they could come in to session the next time and say, hey, I didn't self-harm after X, Y, and Z happened, and I get to say, great job, right? But what we want to do is be able to have them take that and tear it apart with the behavioral change to see how they were able to manage doing that and how they can improve upon that. And then we're going to talk about how they can use it in other settings and for other things as well. Another huge part of DBT and having an adherent program is having consultation to the team. Our consultation team meets every Wednesday. I'm missing it. Or I missed it yesterday because I wasn't there. Every Wednesday at 3 p.m. Or I'm sorry, from 1 to 3 p.m. It's a 2-hour meeting where we do business. We talk about things that are happening on the milieu, things that we may need to change, particular patients, and then we watch videos of each other doing DBT. And that's part of the adherency. And then we talk about, well, it looks like you missed a place to validate there, or you missed, you could have really used some reverence there. So these are all kind of tools in the tool belt of DBT. And so in that way, that helps us keep our skills good, right? Because DBT is a very purposeful and precise mode of therapy. And so there are certain tools that you use at certain times in a session, and we watch the film of each other so that we can keep each other sharp. And then we work a lot with families in order to structure the environment so that the environment can allow the patient to make progress, right? The first thing that we try to teach patients, parents or significant others, or parents of adults or roommates or whoever happens to be in that person's life, job one is stop making it worse. Because there are things that we can do when our loved one or a friend or whatever has severe emotion dysregulation. There's a lot we can do to make that worse instead of better. And so we really start out with families that way. We teach them how to not make it worse as job one.